Hey everyone, today we're going to talk about a question that comes up in the ANZCA primaries, and it's describe the cough reflex. So with this type of question that comes up in the exams, usually you always begin with an intro, and in this intro you want to relate this to anaesthetics or intensive care and why it's important for us to know about it. Then in regards to the cough reflex, you can break it up into Afferent, which is the sensor, the integrator, and then the Efferent, which is the effector. So this is an Afferent integrator effector sort of system that you can talk through. In our introductory statement, we can start off by saying it's a protective reflex. The point of the cough reflex is to remove debris and or foreign bodies from the airway, to clear secretions or sputum, and can help clear lower airway tracts as well. In unwell patients or anaesthetized patients, the cough reflex can be blunted or absent. And for intubation, we need to actually intentionally blunt the reflex, otherwise it would make it difficult to get the tube into the trachea. Otherwise our patients would be coughing while we do all of this. In terms of breaking it down now into the Afferent, integrator and effector systems, or Efferent, we start off with talking about the Afferent system, which is the sensor, and there's really two main nerves we need to know. And it's cranial nerve 9, which is the glossopharyngeal, and this senses the pharynx and upper airway and larynx. And then there's the cranial nerve 10, which is vagus nerve, and particularly the recurrent laryngeal nerve, which is a branch of the vagus nerve, which creates sensation and motor to the larynx. And it also provides sensation to the tracheal mucosa and bronchi. But at this point, it's worth noting that there's no sensation beyond the bronchioles. Here I like to also mention some triggers, so chemical, mechanical, and it can also be voluntary as well. So higher centers can, you can think about coughing and then produce a cough if you wanted to. When we get to integrators, I like to try and connect our afferents to the integration system and to the efferents, because this is sort of the joining point between those two sides of the pathway. So cranial nerve 9, glossopharyngeal, and cranial nerve 10 go to the medulla, and they specifically go to an area called the nucleus tractus solitarius, or NTS. And in the medulla and pons, and remember that the pons just sit above the medulla, there's the integrating respiratory centers. And here, no one really knows exactly where all of these nuclei sit that create the cough, but we know that these nerves go up there, lead to this respiratory integrator system, and this leads to the efferent pathways. So efferent pathways are essentially the effectors of the system. And here it's nice to break it up into a sequence of events to really solidify and show that you know what a cough is and what are the events and the muscles and nerves involved. So in step 1, there's the trigger. So this is as above, we mentioned chemical, mechanical, and then voluntary. And then there's deep inspiration. You take in about 2.5 liters. So our biggest inspiratory muscle is our diaphragm, which is the phrenic nerve from the spinal nerves C3, 4, 5. Your external intercostals, which come from the spinal levels of the corresponding ribs. And then there's also the sometimes the accessory muscles as well that are involved. In step 3, the glottis closes, and this is through the recurrent laryngeal nerve, innervation of the glottis. Your epiglottis also closes as well, it's worth mentioning, and this causes air trapping within the lungs. You then in step 4 have forced expiration, so your expiratory muscles contract against the closed glottis. So this would be your internal intercostals, which again are spinal nerves, and your abdominal muscles, which are spinal nerves as well. In step 4, you have increased transpulmonary pressures, and usually it's quoted at around 100 millimeters of mercury. And then in step 6, you have sudden opening of the glottis, which leads to rapid and turbulent release of air from the lungs. There's also compression, step 7, of the lower airways, the airways that are non-cartilaginous, and that's because of the increased transpulmonary pressures that are produced and pushed on them, as well as all the turbulent air, and you have areas of negative and higher pressures. And essentially the point of this is that you're going to have lots and lots of turbulent air that's going to be pushing through smaller and larger airways, creating more turbulence, which will help create a shearing force against the mucosa, which helps to expel debris and mucus. So the overall result of the cough reflex is the removal of debris from the airway and upper airway to protect the airway and the lungs.